Thank you, Sorsha, for doing this for us as well.
No, that's absolutely fine. Okay, so let's get started. If people want to let anyone who's waiting in the lobby as well, that'd be fantastic. So let's get started. So this woman's history, she's 31 years old. She's a Gravida 2 paranaut. She's had one previous TOP in 2019. Her current BMI is 24. She had an ultrasound for query small for dates at 28 weeks, and this found that it was normal growth and Leica and Dopplers were all normal. She then had a further scan at 36 plus 1 gestation. It's found that placenta was anterior high and normal fetal growth and Dopplers. I'm unsure what the estimated fetal weight was, but it must be within normal range. So let's start. So she came in on the 3rd. At 39 plus 2, she came into triage in early labour. In triage, they examined her. She was 3 centimetres dilated. The blood pressure was raised at 148/90, and because she was in early labour as well, they transferred to delivery suite. So on admission to delivery suite, she started IV Hartmann's and metoclopramide was given, assumingly that she felt potentially sick. Not too sure. And they re-examined again at 01:35, and she was 6 centimetres. So just looking at this CTG trace that we can see here, baseline sitting around 120, I believe, at the start of this trace, and she seems to be contracting probably a good 4 to 5, maybe in 10 minutes. And towards the end of this CTG trace, we see quite a lot of loss of contact as well. And potentially some late or chemoreceptor decelerations there as well. Has anyone else got any comments about this trace so far?
Is the membrane intact, Sorsha?
I believe so, yes.
Right. Yeah, the comment is only that we are not having a clear monitoring in the second half. Yeah. So yeah, maybe terbutaline and then we can put an FSC or something.
Potentially, yeah. I would
Yeah.
again, because of the loss of contact as well, and the fact that she's contracting so much, that is that argument again, isn't it? ARM versus terbutaline. But yeah, I think we definitely, maybe she's in quite a lot of pain. Might be difficult for that reason. She's got a normal BMI, so sort of body habitus isn't an issue here, but potentially, yeah, reassessing that. Has anyone else got any comments? Sorry.
Especially that progressed from 3 to 6 centimeters in 1 hour. So definitely terbutaline and try to get some good monitoring, at least. If not, then FSC. Yeah.
Yes, definitely. As a primary as well, doing very, very well. Perfect. So we'll move on. So this is 2 o'clock, so the CTG seems to have, they've done something well. And we seem to have better contact now at the first part of this CTG trace. We've got baseline remains about 120, we've got accelerations there, we've got regular uterine activity, it's a completely different trace to what we've just seen. And then again, the second part of this CTG trace, so we can see quite a lot of loss of contact as well. And at 02:28, they examined again, and the client is using Entonox, and she is involuntary pushing plus. So it's important to note, obviously, when we are documenting the VE and when we're doing the VE as well, what we're actually finding. So it's not just about 8 centimetres dilated, it's the position, where baby's head is there kappa, is there moulding? It paints a bigger picture rather than just saying 8 centimetres, because she could be 8 centimetres minus 2. And it would completely change the picture of what our plan would be. So I think that's really important, obviously, when we are documenting, to note that as well. But yes, so Naguib, you mentioned obviously that you'd give terbutaline. What do you think now in this part of the CTG trace?
Again, I would personally, seeing the progress that is so quickly, I would be more inclined to give terbutaline, to give this baby a small break, because again, the second half of the first half is fine. The second half, again, I don't know what is happening. I just want a good continuous tracing.
Yeah, I do agree. I think it's a question as well. We don't know what the blood pressure. She was admitted because of the blood pressure, wasn't she? So it might be another indication why is another reason why she's on the CTG other than the blood pressure, because we haven't seen to repeated it since then. That might have also been home related. So would you have, if she was obviously low risk and we didn't have a CTG and she was making this progress, would we have potentially given terbutaline, do you think? Just a question.
Say it again, Sorge.
So if she wasn't on the CTG trace, but she was making this progress, so I think she came in at midnight up 3 centimetres and now at 0228 she's 8 centimetres. If she wasn't on the CTG trace, would we still give terbutaline because she's making this progress, do you think? I'm just thinking because the reason why she's on the trace seems to be just because of blood pressure. I know we've obviously seen some decelerations, but I'm just thinking outside the box. Would
Yeah,
we?
outside the box. If she was on birthing center, for example, and having this like progress with, I'm sure the Sonicaid would have picked up some deceleration here because you know, like in the second half, you would listen to continuously to 80 or 60.
Yeah.
Yeah, in multiple situations. So you would again go to a CTG, like the second half of this CTG, you feel like you don't know whether there is a deceleration or this is maternal heart or this is you want to consider 7 minutes of deceleration, then another 7 minutes of deceleration, or maybe the baby is fine. Looking at the whole trace, you assume that the baby is good baseline. So I mean, medical legally is not defensible in this sense. But and I know people will say, "Oh, she's good, she's nearly delivering," so they are more inclined to leave things in order to let it. But also, I would prepare 40 units of syntocinon because of the precipitate labor.
Yes. Completely agree with the uterus the way it is. Okay, good. Thank you for that. So yes, we're here. So we're 8 centimeters dilated. She's using entox. She's involuntary push, which makes me think this probably will be quite a quick labour. In regards to the monitoring, will we do anything? So I know we mentioned before terbutaline and potentially an FSC if she hadn't trommed. But what else could we potentially do? Or anyone drastically concerned running to theatre right now? No? Okay. It's a good sign. So sit and wait approach if she's making adequate progress. Again, we want to focus on actually that monitoring and making sure we've got a good sort of trace throughout. So we will continue. So at
If
0240, sorry.
Sorry, Sorsha, if anybody of my colleagues, registrars or midwives have a different opinion, we would like to hear it from.
Yeah, this is a learning environment, so this is an opportunity for us to discuss a case. No one's judged, everyone's going to have a voice. And this is where you can ask those questions that you might have pressing that maybe you had in placement or when you had a trace similar. But we will move on if no one has anything. So 0246, the midwife in charge was present and was advised to give terbutaline as she was contracting 5 in 10. Obstetric registrar had agreed for this. So 0248, 250 micrograms of terbutaline was given, hopefully subcutaneously. So it's around here that she had the terbutaline. So what do we think of this CTG trace? So based on sort of before was about 120. Are we all happy to continue? Yeah. So she's had some
Yep.
decelerations beforehand, so we're given the terbutaline, so we're hoping that the decelerations and the stress that we're causing, the contractions, ease up after the terbutaline. And we've got better trace, probably the longest part of the trace that we've had that's been quite good contact throughout. We can see she's got good variability. She is having some decelerations with the contractions, but she was contracting quite a lot. We still remain probably 3 in 10 to about 4 in 10 towards the back end of the CTG trace. But yes, so we're all happy to continue with this CTG trace. She's 8 centimetres about half an hour ago. Terbutaline may subside some of the contractions, but shouldn't interrupt labour too much. So we will continue. So at 03:36, the midwife notes she's continuously involuntary pushing. So decision was made to examine to see if she was also fully dilated and ready to push. She was now 9 centimetres dilated and obviously evacuated her bowels as well. And we can see at the start of this trace as well, baseline seems to be about 120, 130. Quite a lot of loss of contact again. And she seems to be back to contracting about 4 in 10, 4 to 5 in 10 in some of these as well. The registrar reviewed at 04:05, and she was again 9 centimetres dilated, and the plan was for trial in theatre, but the patient declined this and wanted to stay in the room. So what do we think of that situation? If we do have a woman who is 9 centimetres with a CTG similar to this, who declines trial, the head must be fairly low, I'm assuming, for the registrar to decide at 4 o'clock in the morning that they're happy to go for a trial. But what is everyone else thinking?
Sorry, did I miss that? She's 9 centimetres and we're taking her for a trial.
Yes.
And she's primate.
Yeah. Exactly the same as what I was thinking. Yeah.
And did anyone discuss with her epidural if she's involuntary pushing and she's in pain, and why is she declining? Or I mean, I'm glad she's declining trial, but
yeah.
Is there any more documentation, please?
Not that I'm aware of. I can look at the bottom of this. Not that I'm aware of. No, everything is as it is here. Unfortunately, I'm sorry.
I'm feeling slightly sorry that the registrar at this point, I don't know. I'm putting myself in his or her shoes. I feel that the registrar is facing a situation where he or she is not able to get her to accept epidural. So he or she is getting her to theater to have a spinal. So not really for it. I don't know. I'm feeling that there is something behind the documentation. I'm sure nobody will take anybody for trial for at 9, but somebody who is opening bowels. This means the membrane or the head is so low to push everything out, as if this registrar is feeling, if I am in theater, spinal is in, she will be fully. So, and the lady is so, again, it's not written or it's not said, but I feel like he or she wants to say, this lady is so difficult from the beginning. For example, I tried to convince her to have something. She's not listening. Let me put her under anesthesia so I can deal with her. I don't know. I
Yeah.
don't think it. I don't think it is a CTG management at this point of time. I feel it is a woman management.
Yeah.
But Mr. Naguib, if this is the case, and this is what we're presuming in the lack of documentation, this kind of indicates even more explanation on paper and more documentation. Obviously, because if anything goes wrong, how is this person going to defend him or herself on going to theatre at 9 centimetres with no kind of like a proper documented discussion? I think when you're going against the norm, it kind of justifies even going further in your documentation and your explanation of the thought process.
I agree with you 150%, Maya. The problem is, and as most of the people know, when I went for a twice for coroner inquests, and once for GMC investigation. The main criticism that anybody has done to any doctor in any difficult situation is lack of documentation. And whenever the lawyers and experts see lots of documentation and the thought process behind it, there was a lot of defensible uh, argument with them, with their MDU lawyer. So I can't agree with you more. If you are going in this specific situation to theater, and you know very well that the college guideline tells you you cannot do a trial without being fully dilated, without the head being at spines or below, and you need to have at least a page of documentation of what is your thought process.
Would you have considered a second terbutaline at this stage?
Yeah,
I
was
would.
just thinking that.
I would definitely consider it even before,
Mm.
in order to. So the dilemma of terbutaline and ARM we have discussed, and I know Sorsha has listened to this argument before multiple times, and the dilemma was solved for me at least when I was in St. George's with Mr. Ogumado, and he said to me, if you ARM somebody who is contracting 5 and 10, you are going with a train that is going 50 miles per hour to 100 miles per hour. So slow down the train first with terbutaline, and then you can ARM. So I would, yes, I would earlier given a second terbutaline, for example, then ARM, in order for me to achieve the head descent plus uh, possible fully dilated, plus possibly fetal scalp electrode, many things. So I would, yes.
Wonderful, thank you. I'm assuming that she potentially has strummed at this point, just because it hasn't documented. So she must have strummed maybe at home. I'm not too sure. It's just not documented. But we will continue. So the previous ones are 0405, 0425. At the end of the CTG trace, the patient has been agreed to go to transfer to theatre, but for trial, but not for caesarean section. Now, from this trace as well, we know the previous baseline was about 120, and a lot of this trace isn't around that at all. So it's difficult to interpret. But again, from the documentation, the patient has agreed to go to theatre for trial, but not for caesarean section. It does make me wonder what the conversation potentially was regarding going to theatre. Was it to do with pain relief, as you mentioned before? So that's why, potentially. What's everyone else's thoughts?
Did they give terbutaline prior to moving to theater?
No.
So this is, I would have done this if I'm moving and trying to get spinal in, which will take 10 minutes, 15 minutes to work. I would be more terbutaline oriented to get it. Again, this is a personal experience. I don't have evidence to support it. In 99 of cases, when I see bowels opened, the head is +1 to +2. I know this is very anecdotal, but like, and none of those needed to go to theater. But again, this is something, it's not written in the notes, so I don't know. But at least terbutaline before moving to theater.
I think this is a case of managing a difficult patient more than CTG, to be fairly honest. It sounds like she's a very difficult one, Sorsha. Yeah. And she's already kind of saying, I'm not for C-section. Obviously, again, documentation would have helped a lot. We are moving to subacute picture here, but I was wondering, Mr. Naguib, do you think in such a case when she's progressing really quick and, kind of like hoping for a very quick delivery, Now, ARMing her would really make the CTG worse, but would you hope that that would kind of even expedite things better and she would deliver before moving to theatre? Would you have considered that?
You know, Maya, I would if head is very low and I am confident that I can grab this baby with the ventouses after I ARM. So ARM, prolonged bradycardia, I am happy that more or less I'm going to achieve delivery if I want within the next 5 minutes, more or less. Yeah.
Thank you. So they transferred to theatre at 04:45. The spinal was inserted, probably for pain relief purposes to start with. At 04:55, the client wants mother to make the decision for her, so they brought the mother into theatre. A lot of this seems to be painting a picture a bit more, doesn't it? At 05:01, she was fully dilated. 05:06, cup was applied but not working. At 05:09, Kiwi was applied and first pull, but there was minimal descent, and the decision was made for a category 1 emergency cesarean section. So 05:17, knife to skin, 05:18, knife to uterus, and 05:19, delivery. So just being aware as well that we pretty much, our baseline before was 120. Now we're sitting around 140 when the spinal was inserted, and then at 04:55 when they went to go get the mother for decision, we sort of had quite a lot of loss of contact and pretty much a prolonged bradycardia here. So never really recovers for longer than probably less than a minute or so here. So if we're thinking about how this may affect the fetus as well, and these are all 10-minute segments, we're looking at a sort of a 10, 20, 25-ish since we've been at baseline. So what are we all thinking? What do we think about this, Trace, and the plan?
I mean, we definitely knew she's coming with subacute, so having spinal would only move it to acute. I mean, this is something you do anticipate. With the vasodilatory effect of the spinal, there will be kind of decreased placental flow, and you will end up moving from subacute to acute. I mean, it depends on the examination. Again, documentation in this, like, what does it mean, cup not working? Is it the actual cup not working, or
suction? I don't know. I'm not too sure. The fact that
like how much caput, how much molding would I, assuming she's OA, would I have chosen forceps? There's quite ambiguity in this case. Like, I think there's something doesn't sound right. Like, if it was OA, was it rotational? How high? And when was she ARM'd as well? There's really gap in documentation in this case, big gap.
I think that's a really valid point as well, and I think we can all sort of learn from that in itself as well, that actually at 4 or 5 o'clock in the morning, obviously we've got that human factors element, that sort of circadian rhythm, we're at most tired as well. But how important documentation is, it's great for us on hindsight when we're looking back, but actually it can paint a massive picture as well. If this was a poor outcome case and you had to go to coroners, or it was a HSIB case and you had to write a report regarding this, or a statement, it's important that that documentation is absolutely flawless, if anything, and actually paints the picture, because we will have difficult patients, we will have obviously difficult situations that may not necessarily be surrounded by the CTG, as we've sort of mentioned. It could be related around spinal, but it helps to paint that picture a bit better and sort of understanding what is happening. So it's a really valid point how important documentation is.
I think it is. I think it is a self-inflicted situation, to be honest with you, Sosha. We were saying a while ago, give terbutaline before moving. It wasn't. Number two, there is no sense of knowing or telling us at least, or documenting where is the head. Because a fully dilated, the lady is opening her bowels. This assumes that head is low. Cup is applied. I think when they say cup applied and not working, most likely the person was using the metal cup, but the suction is not working, or the person operating the machine here is not knowing the logistics of the metal cup. So the suction is not working, or the pedal is not pressed. Then there is a panic situation here where I don't know what to do. Let me put a kiwi. Similar to what Maya says, like you are moving from a metal cup or that hasn't worked to a kiwi. I'm not sure whether the kiwi is with one pull, minimal descent, as if you want to tell in the documentation that it was is a failed instrumental cesarean. So you wanted to give it like a fake pull. The whole situation doesn't sound absolutely right. Similarly, uh, I think part of the problem here that is not manifested is the patient being difficult, possibly. And so the decision making of the operator might be influenced by the stress related to the patient herself. So I cannot say exactly what is happening and whether a forceps would have worked or not, because I don't know from this documentation in front of me in the slide if the head was low. What is the position of the head? Was the lady screaming in theater? So there is lots of elements here that is weird to me. As if we cannot comment fully on that. And when it went on for a few minutes, or let's say more than 10, 15 minutes, I think at this point of time, you feel, I don't have any other solution except the cat one. So yeah, I think documentation, or maybe it is a very busy night where you cannot document a lot, and so I feel possibly it is a fantastic obstetrician that has done the right decision, but at the same time, it from the documentation is not obvious. So was it said in the notes of the instrumental at least?
Yeah, I don't have that, unfortunately, but this is it. But yeah, I see what you mean, definitely, and that's sort of the best you
Yeah.
can.
Mr. Naguib, may I make a comment?
Yes, please.
I think we're always incredibly scared of arresting labor. Like we are really terrified of kind of if someone's progressing really well. And I think in this one, because she was progressing so well, whoever was delivering her was kind of like really um, kind of like reluctant to kind of arrest that fast progress of labor. But I think if you mentioned if it was a very busy night, even more reasons to give her more time to kind of like pause things, reassess, and restart again. We can always titrate it later and start center. That's not the end of the world. But I think this lady ended up in a cesarean section because we were trying to kind of like keep on pushing with a very, very speedy progressing labor. And I think if we gave that pause for this baby to rest a little bit with a second terbutaline, that would have changed the outcome of this delivery.
I agree with you, Maya, and I have many situations in my life where I did the mistake and rushed, and I didn't end up with a cat one. I will be honest with you. I ended up with delivering because of the panic. In this situation, I put a forceps on, and I caused a 3C tear in 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 multiple times. I must admit, and the panic behind it was I am having an HIE baby. Let me save the baby, and I will solve the problem of the mother. Um, yes, giving terbutaline even at full dilatation and resting. And if I want to do a trial and the trial is not satisfactory in the room, I would give terbutaline and move to theater and do the trial in theater in a better condition and after allowing half an hour or so. And I can start the Synto in theater, not at 3, not at 6. I can start straight at 12 or even more because I have the instrument in my hand. This is number one. Number two, what is not obvious here, whether there was a narrow pubic arch, whether it was big baby. So again, these factors are very important in the documentation. So I am completely in agreement with you. Stopping and reassessing the situation with terbutaline, especially when you have reached the climax of the situation, which is full dilatation, I think is very important art to play with the baby and the pelvis at this time very nicely in order to achieve what you want. It might have ended anyway with a cesarean, like maybe if it was me, I would have said, you know, the head is high. I cannot even attempt a instrumental, and I will go straight for a cesarean when I am in theater. But why did I end up in theater in the first instance? I didn't understand from the CTG. Why are we attempting a trial at 9 centimeter? This shows me the obstetrician was confident that I can deliver this baby at 9, not at 9, but I mean, I can possibly push the cervix forward and pull it out. So again, the whole scenario makes me feel that I am tired at 4 o'clock in the morning, and I was in this situation before. 4 o'clock in the morning, my decision making is not at its best, and it is busy. There is one decelerating in the room. I need to rush her to theater. There is another one in triage that is needing this. So I need to deliver this by all costs so I can get on with my work. Again, in this situation, I would advise the registrar to say, hang on, the patient is first. I will get the phone. I will call whoever is on call, even if Naguib gets upset because he's woken up at 3 o'clock in the morning, 4 o'clock in the morning. I'm sorry, and I'm saying this to you all. I don't care. Let Naguib be upset, but the woman gets better. The consultant needs to come. Fine, fair enough. We want 2 registrars in the night, and it hasn't manifested yet. So registrar is busy. It is getting weird. It is getting pear-shaped. I'm making decision that looks to me slightly outside the box. Hello, I have 3 ladies in labor with suspicious CTG. I need to do something with this woman, and there is other things. Please come. I'm sorry. Thank you very much. Yeah.
I think that's a really good point. It's your fresh eyes as well, isn't it? Someone who is coming from the outside in. So yeah, I think that's the beauty of having someone that you can call on as well for an on-call. Really valid point. Thank you, Naguib, for that. We'll move on. So this baby was born via a category 1 emergency cesarean section with APGARs of 9, 10 and 10. Baby weighed 2935 grams on the 14th centile. And gases are, as you can see here, arterial was 7.05 with a basic excess of -12 and a high lactate of 10, and a venous pH of 7.08 with a basic excess of 11 and a lactate of 9 with a glucose of 6.2. So I think it's a good example of probably what's happened in sort of an acute hypoxia bradycardia, post-spinal, but also quite a precipitate labour as well, and probably quite a stressful situation, and the mother was quite panicked. But baby was on the smaller side, which may have impacted obviously the reserves that this fetus had. It didn't necessarily, we mentioned about a big baby earlier, and that may have had another impact on obviously why they didn't do an instrumental, or there was difficulty with an instrumental maybe. But I think it might have been a whole clinical situation. Like we mentioned, it's more about the situation rather than the CTG. But I think this is really evident of an acute hypoxia here. Has anyone got anything else to say about the findings at the end?
Yeah, one thing, Sorsha, please. Many people I see commenting on in the meeting that we do on Friday, and we are sitting all of us and happy and sipping our uh, coffee and eating our lunch, and then we see this is, for example, a neonatal admission, and we say, "Oh, the baby is small, 14 centile, it should have come." It's not. It's not. And many babies who are small or like 14 centile, 10 centile, but the pelvis of the woman is so narrow, with narrow pubic arch, with is contracted exit. Uh, it might not happen. So this is for my colleague registrars here who are going to be consultants, and some of them will be doing the risk management. Don't overjudge. Oh, this was a big, small baby. It should have come. This is rubbish, instrumental. It's not. The cephalopelvic disproportion cannot be assessed except really after, like delivery, or you cannot assess it in prospect or in retrospect. You cannot do it, and don't judge like this. So that's just a comment for the future consultants, really.
Wonderful, thank you, Nikki. Has anyone else got any comments? Okay, that was a quick one this evening. So thank you for everyone that took part, and I appreciate it. So thank you for coming. I think Cara's back next week. If not, I'll do another one. So thank you for coming.
Thank you so much. Thank you so
Thank you
much,
so much.
Sorcha,
Perfect.
for
Thank
doing
you
it
so
for
much.
Cara.
Thank
Thank you so
you.
much.
Thank you.